Chapter 10 focuses on conducting a thorough and accurate pain assessment. In order to get the most out of your textbook, be sure to review the anatomy and physiology at the beginning of the chapter. Consider the different sources of pain and how they can be alleviated. For example, nociceptive pain is responsive to treatment with opiates and NSAIDs, whereas neuropathic pain is responsive to antidepressants, anticonvulsants, and anesthetics. And when you're treating a patient who has end-stage cancer pain, we treat them with whatever works best for them. Be aware that there are variances in presentation based on age, gender, culture, and genetics. Review the subjective data presented in this chapter and the rationale for asking those questions. Just glance over the different pain assessment tools, and we're going to cover them a little bit more in this discussion. Read the objective data and be able to differentiate between normal and abnormal findings. Always review the documentation and critical thinking at the end of each chapter, and read the examples and case studies provided to help solidify your understanding of the material. At the end, there's a summary of abnormal findings and treatment options that is really an excellent review of the treatment of pain. The very last page in this chapter gives a brief explanation of RSD, which we'll talk about more in our second semester. When you're conducting a verbal pain assessment, you want to take a good history of the present illness. Onset. What were you doing when it started, and when was that? Let's take, for example, a patient who has chest pain. There's a big difference in the patient who presents with chest pain at rest that woke them out of sleep versus the patient who has chest pain that started while they were shoveling snow or mowing the lawn. Is there anything that makes it better or worse? Be sure that when you're asking questions like provocation and palliation, that you use layman's terms. Patients don't understand our medical terms, and so if you say to somebody, "Does anything provoke it?" they may not understand what you're asking, and so they may just say no. Ask questions to help clarify the quality of the pain. What does it feel like? Could you describe it for me? Sometimes we also ask questions about quantity, like how many times has this happened? Or how many episodes have you had? The region that the patient is having pain. So where is the pain, and does it go anywhere else? So does it radiate anywhere else? And this helps us distinguish what underlying structures or organs might be involved. Because pain radiates along nerve tracts, most organs follow a very predictable pathway of radiating pain. Severity. Severity is a very subjective description. So you want to ask on a scale of 1 to 10 if 0 is no pain at all, and 1 to 2 is discomfort, 3 to 4 is mild, 5 to 6 is moderate, 7 to 8 is severe, and 9 to 10 is unbearable. 10 is the worst pain you've ever had in your entire life. How bad is your pain right now? How bad has it been at its worst? How low has it been at its best? What is an acceptable pain severity for you? When we're thinking about pain management at the RN level, we want to establish a pain goal for the patient, including a severity that the patient feels is tolerable. Timing. So in your book, I noticed that it includes onset and timing, but traditionally, timing really means how has the pain changed since the onset? Does the pain wax and wane? So does it come and go? Has it steadily increased since the onset? Is it constant? Is it there only in the morning or only in the afternoon after you walk up a flight of stairs? Is the pain there only after you eat? Or does it get better after you eat? So think about what the timing of the pain pattern says to you. And then you. And you is something very important. Ask the patient at the end, thank you for sharing all this information with me. I have one more question for you. What do you think is going on? What do you think this is? Getting the patient's impression is critical. And I want to share a story with you. So it was a busy day. I was triaging, and I had a patient write on their card, toe pain. And so I triaged abdominal pain and an eye injury first. And then I bring this very nice 50-year-old woman back into triage. And I, say, my name is Inga. I'm going to be your nurse today. Would you mind sitting in the chair so I can check your vital signs? And I'm just going to ask you a couple questions and get you triaged. And she was very pleasant, and I'm taking her vital signs, and I'm going through the OPQ-STU. And so I say, so tell me what hurts. And she says, my left toe. And I said, did you injure it? And she said, no. And I said, well, when did that start? And she said, kind of early afternoon. And I said, what were you doing? And she said, I was just sitting on the couch. And I said, okay, do you have any pets or, any reason, like, do you clip your toenails or any reason to believe that it could be an infection? And she said, no. And I said, well, is there anything that seems to make it better or worse? And she said, it gets a little worse when I walk. And I said, tell me what it feels like. She said, it's just a dull ache, like a throb. I said, does it go anywhere else? And she said, maybe up my leg a little. I said, how bad is it? She said, like a 3 or a 4. And of course, in my mind, I'm starting to think, why in the world are you here in the ER on such a busy night? But I don't say anything. And I said, so since the onset, has it changed at all? And she said, well, it's progressively getting a little bit worse. And I said, okay, thank you for sharing all of that with me. One last question, do you have any idea what's going on? What do you think it is? And she said, oh, well, this is exactly the same symptoms I had when I had a heart attack 3 years ago, and I had to have quadruple bypass. So I'm thinking okay, well, you should have led with that. But just such a critical question, because sometimes if we don't ask, we won't get the information. In your book on 168 and 169, they give you some examples of overall pain assessment tools. We're not going to spend any time on that because every facility that you go to is going to use a different pain assessment tool. My recommendation is wherever you go, just learn the paperwork and the charting system that they have there, and make sure that you feel comfortable doing a good physical exam and asking all of those important questions. What I do want you, though, to be able to recognize is that there are pain rating scales that you need to be able to use. And the reason that we use pain rating scales is because it improves interrelator reliability. So if I ask on a scale of 1 to 10 and you use faces and somebody else uses the visual analog scale, that decreases the interrelator reliability, or interrelated reliability. So really what we're looking at is how accurately can we assess the same thing, compare apples to apples, basically over and over again, in order to determine if we're improving, getting worse, or staying the same. So the numeric scale is the 1 to 10. The simple descriptive scale is the words. So it's, discomfort, mild, moderate, severe, unbearable. The visual analog scale is the one that gives different degrees of, usually a red. So from like a pale, either pink, white, or yellow, all the way up to a dark red, and dark red being the worst pain possible. So those oftentimes are combined, and they're combined so that on a card, when you're doing triage or taking care of a patient, you can use all 3 of those, the numbers, the words, and the colors, and sometimes even the faces are combined as well onto that in order to get the best pain assessment possible. But just make sure that you're using the same tool over and over again when you do your ratings. Faces, Flacc, cries are used for children and infants, people who can't necessarily communicate or won't give you a reliable number or word. And then PAIN-AD is the pain assessment in advanced dementia for our dementia clients or our nonverbal patients, and that's looking at their their actions and their vital signs to determine how agitated and uncomfortable they are. So this is one of those combined scale cards. I find these to be incredibly helpful. So this has the visual analog scale, it has the faces scale, it has the verbal, and it has the numeric scale. And it has the verbal for both pediatrics and for adults, right? So for adults, it has the no pain, mild, moderate, severe, and worst imaginable pain. And for kids, it has the no hurt, hurts a little more, hurts even more, hurts a whole lot, hurts worse. Depending on where you work, most places now have, not only do you chart the pain, but you also chart the score or the scale that you used so that the next person who's assessing the pain can use the same scale. The CRIES neonatal postoperative tool is used to assess postoperative pain in the neonate who's too young to use verbal responses, obviously. So you can see very similar to APGAR, it looks at crying, oxygenation, vital signs, their grimace or expression, and their consolability or sleeplessness. And it's scored on a 0, 1, or 2. The higher the scale, the higher the score, the worse the pain. So if they were inconsolable, needing oxygenation, and tachycardic, tachypnic, with grimacing, grunting, and unable to sleep, that would score them essentially a 10 on 10 pain. If they were not crying, had good oxygenation, normal vital signs, appeared comfortable, and were able to sleep, then that would give them a 0 on 10 pain. So basically we're just looking at, how comfortable the child appears based on their facial expressions and their vital signs. The Flacc scale is, again, based on children who are too young to really verbalize how they're feeling, so it's nonverbal behaviors. This can also be used on older children or people who are cognitively impaired. But because we're looking at legs, activity, and cry, really it's meant for our younger children, ideally. So for older kids now, we're kind of using that, the advanced dementia pain scale a little bit more. A lot of times you're just going to use kind of your provider impression for pain assessment, just, because you can't get the child to give you a number, or can't get the person to give you a number. So this looks at face, legs, activity, crying, consolability. Again, very similar to an APGAR. And then the pain assessment in advanced dementia patients. So you're looking at breathing independent of vocalization. So is it normal, occasionally labored, or noisy and labored? You're looking at negative vocalization, so that would be evidence of groaning, moaning, pain, repeatedly calling out, crying. If you've worked with somebody who has dementia and you've noticed those kind of continued verbal agitated behaviors, what we find is that chances are they're actually in pain from something. It might be something as simple as they're constipated, they need to go to the bathroom and they don't recognize it, or they're, retaining their urine. They may have gas, they may have a wrinkle or some sort of like fold in their clothing, but something is uncomfortable for them. And so it's important as the RN to recognize that, that kind of agitation, combativeness, vocalization, tachypnea, and the inability to distract and kind of reorient the patient with advanced dementia, there's a good chance that they're uncomfortable or in pain, and we need to intervene in some manner to make them more comfortable. Don't write it off to being just a progression of the disease. Really look for an underlying cause. Check their skin, check to make sure they're not wet or soiled, check to make sure that they're not thirsty or hungry, check to make sure that there's not something else going on.